So we move on to the next topic, understanding complex strabismus. I invite Professor Dr. Pradeep Sharma.
Thank you, Farnaz. I would like to thank Dr. Santosh and Dr. Namrata for making it possible for me to be here with you all. Feroz was asking who is a postgraduate. I had raised my hand because postgraduate is only an entry point. There is no end point. So you always remain a postgraduate after your graduation. You keep learning. And that's what we have to do. Understanding complex strabismus is the topic which was given to me. And I have no financial interest involved of any kind except for your love and affection, which I always aspire to. So today we have to talk on understanding complex strabismus, the non-paralytic kind. At one time, probably strabismus itself was considered complex. But now I think most of you don't find it as complex, and it has got narrowed down to non-paralytic complex strabismus, and that's what we're going to talk today. So this is a quiz question. What do you see here? Anybody? What would be a diagnosis? So in the PG, I think in the exams, many a times, this may come up. So what do you find? That there is, in the primary position, esotropia. On the abduction of the left eye, you find the limited abduction. And on attempting adduction, you find narrowing of the palpebral aperture. You find the retraction of the left eye. And also you find that there is a tendency for downshoot in this, and much more in the other gazes. You'll see upshoots and downshoots. So what does it mean? Yeah, loudly? Huh? Duane's retraction syndrome, ESO-DRS, or esotropic Duane's retraction syndrome. So you're right, it's a left ESO-DRS. Esotropia in primary position. Usually these children will come with a face turn. Why a face turn? Because they have a tendency to get back their binocular vision, and in the left side face turn, they can have the left eye ESO, the right eye is free to move, so they can keep on retaining their binocular vision. So they have a face turn, and you will typically see a marked upshoot, retraction in adduction, and a limited abduction, and also a limited adduction. Now here there is this is an exo-DRS. What do you find? In the primary position, there is an exotropia of the right eye. Again, a limited abduction. But on attempted adduction, you find a retraction, narrowing, and upshoots and downshoots. Sometimes the exo-DRS are more horrific looking. So this is also a Duane's retraction syndrome, but exotropic kind. Duane's retraction syndrome, for more theory, if you just want to know, it's 1 to 4% of the pool of strabismic patients. And female preponderance is there, about 60%. Left eye is more commonly involved. And 71% the DRS may have associated refractive error. So they may have amblyopia, not necessarily because of strabismus, but because of associated refractive error. The most common type is ESO-Duane's, and the next is exo-Duane's. And the reason behind Duane's retraction syndrome nerve, we know, is a nerve problem. It's the problem in the development of the sixth nerve. So nowadays we call this as a group of cranial disinnervation disorder, a congenital cranial disinnervation disorder, or a CCDD. Okay? And CCDD always has a primary disinnervation. In this case, it's a sixth nerve problem. And the secondary disinnervation is the abnormal paradoxic innervation which is happening. So when does this problem happen? Usually it is happening in the first trimester of our birth. And this is, if you want to go into more detail, Huber has described type 1, type 2, type 3 on the basis of innervation. So if you find that the abduction, there is no innervation coming to the lateral rectus, but on adduction, you find the lateral rectus gets innervation. It's like if you're sharing a room with your PG, and that other guy doesn't study when he has to study, and when you want to study, he interferes. So that is a paradoxic innervation. Doesn't want you also to work, and himself he doesn't study. So that is a kind of paradoxic innervation which explains Duane's retraction syndrome. A type 2 is one in which you'll find that there is some abduction is there because there is an innervation coming on the sixth nerve. So this is the kind, the boy who studies himself, but when it's your turn to study, he doesn't let you study. So this is another kind of problem. And there are third kind in which it's always interfering. the type 3, in which both innervation, abduction, adduction are affected. There are some associated syndromes which you should be aware, like Golden Heart syndrome, the Klippel-Feil, the Wilder-Wang syndrome, Holt-Oram, Okihiro, and IVIC syndrome. So these are associated problems. What is happening in embryogenesis, in 4 to 8 weeks of embryogenesis, we have found that this problem is happening. Some common culprits are the thalidomide and misoprostol. The problem is with the higher estrogen level and inflammation during this period of development. It's a thromboembolic problem which is happening, and that is the reason why it is affecting more commonly females and the left side. So if we can control the problems of thrombogenic influences such as malnutrition, dehydration, alcohol intake during pregnancy, infections, trauma, ionizing radiations, or some of these conditions, we may prevent Duane's retraction syndrome. So remember, DRS is a condition in which there is paradoxic innervation of the muscles, and the lateral rectus is getting a paradoxic innervation during adduction. How do you manage this? First of all, see whether it's an ESO, EXO, or ortho. If it is ortho, many a times you may just keep it till the time you get a person whom you can send him that, okay, now you handle this case. So otherwise, ESO and EXO may be required to be managed because of the deviation which is manifest. How significant is the co-contraction is what you'll see. How this will be seen by the upshoots and downshoots. A retraction will always be there because it's a co-contraction is there. But the upshoots and downshoots are there if there is a severe co-contraction. Then thirdly, you see how much is the normal LR activity. And fourth point, look for force reduction test, whether the FDT is positive for both the MR and LR or only for the MR. And accordingly, you will tackle them. So for example, now this case is ESO-DRS. FDT is free for MR. There is a minimal co-contraction. We have just done by improving the abduction by a superior rectus transposition. That's it, and that case is fine. Another situation, FDT is positive. So here you have to do an MR recession. But mind you, in DRS cases, whenever you do an MR recession, it should be minimal as required for the FDT. If you do little more, you are in trouble. So this is 4 millimeters of recession of MR, and you are fine. In extra MR recession, because of co-contraction, will lead to a iatrogenic synergistic divergence syndrome. Okay? Like this picture you see here, the next day the person has a exo, a deviation from ESO deviation on the pre-op position. So here you will have to then tackle the lateral rectus. So in ESO-DRS, if there is a severe co-contraction, always remember that both MR and LR have to be recessed. No resection, only recession of both MR and LR, but here you have to counter them so that the retraction is corrected as well as you do not get a synergistic divergence. And the LR is also a Y-split. So this is what is the take home for an ESO-DRS. There is a planning algorithm. If you are interested in more details, you can go and read in the IGO 2019. How do you manage the EXO-DRS? So here the LR is to be recessed or it has to be taken away altogether. This will depend on whether you have an abduction or not. If there is some abduction, you want to conserve the lateral rectus. If there is no abduction at all, you can sacrifice the lateral rectus altogether by doing a periosteal fixation of LR or doing a very supramaximal recession. But if there is an abduction, you want to only limit. It's like a corrigible convict. You can penalize it and with the Y-split and leave it still there. So in this case, for example, an LR recession of 12 millimeters with 21 millimeter Y-split has been done, and you find the EXO-DRS in the left eye gets corrected. There is abduction which is again conserved because you haven't sacrificed the lateral rectus fully, and this on adduction he is much better, what you see here. But on the other hand, if you find there is a very strong co-contraction, you will have to do a large recession of the lateral rectus, or you might do a supramaximal recession. So again, for details, you can go in for the IGO talk. This periosteal fixation when we are doing, you may improve the abduction by doing some transposition procedures like a partial VRT or nowadays the Nishida's procedure. For example, in this case, you see the Duane's retraction syndrome, the movements are there because we have been able to manage the improvement of abduction. EXO-DRS left here, and you have done a recession of the lateral rectus with Y-split and a modified Nishida procedure. Ortho have a problem. The challenge here is to retain the ortho in the primary position and still correct the problem which is happening in the adduction. So this is how do we manage? We'll have to ensure that the ESO or exo, both forces have to be balanced. So you have to do a controlled, again, recession of both medial and delta rectus in the same eye. No resections. But here it will be a balanced one. So medial rectus may be on an adjustable suture so that you can ensure the ortho position in the primary position and weaken the paradoxic innervation of the lateral rectus. So to conclude the DRS talk, you have these take-home points that you will always keep in mind, and never do an SRT, IRT or VRT unless you have taken care of the paradoxic innervation or the co-contraction. Now this is another quiz. Now what do you find here? What is there in this case? Anybody shout? What do you find in the left eye, in the right eye, in looking in levo elevation? The eye doesn't move up. There is lack of elevation of the right eye in levo elevation. But on dextro elevation, it is moving good. And in the straight up gaze, what do you find? There is a little divergence coming in. So the diagnosis here would be a Brown syndrome. And clinically, when they present, these children come with a chin up position. Why? Because they have a problem in maintaining the eyes straight or in looking up. But down gazes are usually okay. And so they may be having a chin up position. So Brown syndrome, these are the features, 3 key features you have to remember as a PG. Limited elevation in adduction, normal elevation in abduction, and a divergence in up gaze, or like a Y pattern in up gaze. If you have these 3 points, you will always have a Brown syndrome. Keep it in mind. And in addition, look for if there is an associated superior oblique overaction. Then it becomes a Brown plus. If you look into the fundus, you might see an intorsion in this. So this is a Brown syndrome right eye, post-op, after the same case which you saw earlier. Sometimes you may have a Brown's in one eye and the other eye is having a superior oblique palsy. It may appear very odd, they are opposites, but it's not. Because the Brown syndrome, there is a problem again with the superior oblique. It's a fibrotic or a tight superior oblique. On the other side, it may become so fibrous at times, it may snap and it will give rise to a superior oblique palsy. And sometimes some iatrogenic superior oblique palsy you may see if somebody has done a superior oblique free tenotomies. So that you have to keep in mind. So these are the procedures that you have for superior oblique weakening, and the choice procedures from very mild cases a PTSO, but otherwise you do a hangback loop tenotomy or a recession and translational recessions. A silicone expander is also one of the procedures which can be done. Now here I show you a case of iatrogenic superior oblique tenotomy done, which I would say never do in cases. You never do free tenotomies or myectomies of inferior oblique in obliques. So this is a right Brown plus in which superior oblique overaction is there, and after this surgery you'll find after the hangback recession, the adduction, the elevation is good, and of course the elevation was good in abduction. Now what is this? This is a Mobius syndrome, another complex problem which we deal with. Children with these eyes have ESO deviations in both the eyes many a times, and also what you should look for is the 7th nerve. So there is a facial paresis in one side. So as you see, if he's closing the eyes, he cannot close the eyes fully. The smile is half. And so this is a 6th and 7th nerve involvement. And along with that, there may be other problems like talipes equinovarus. So these children, if you see, this is what may be there. And how do we manage these cases? We will have to do a FDT of the MR and recess it equitably to correct that ESO deviation in primary position. There may be also bifid tongue, like in the lower part of the picture. Again, what is happening, if you see the problem, is a 6th nerve abnormal development, and here there is a fibrosis which has happened, which has created this problem. Now we come to the 3rd nerve which can create problems. In 3rd nerve, what we have is a congenital fibrosis of extraocular muscles, the CFEOM, and these children will typically have a perverted convergence on attempted up gaze. So the key feature to take home is, ask them to look up, and if you find the eyes are converging, you will have a perverted convergence, means most likely it's a CFEOM or congenital fibrosis of extraocular muscles. Don't confuse by the terms CPEO. Many times the PGs get confused. A CPEO is a totally different thing. It's a chronic progressive external ophthalmoplegia, nothing to do with this. This is a CFEOM. And here the problem is development of 3rd nerve embryogenically, and there are other problems which are happening. And this is again, you can take a picture of this. There are different types of CFUMs. CFUM type 1 phenotype 2. The 1 and 3 are commonly seen. Sometimes we see the Tuchel syndrome with oligodactyly, that means a short finger, and the CFUM5. The unilateral, which we see, is CFUM3. Otherwise, many of them are bilateral ptosis and bilateral ocular involvement problem. So this is a case of CFUM. These are, mind you, more difficult to manage because there is the third nerve muscles have been involved. So it's a very complex problem, one of the more complex, I'll say. And here we have to do an FDT again and weaken the lateral rectus. Sometimes the IR recessions have to be done very much, and for the ptosis, the crutch glasses may have to be done. Now, what do you see here? This is, can you see this video? Now here, the child is looking on one side. When he abducts the left eye, you'll find the right eye is abducting much more. So the right eye is a problematic eye in which there is no adduction. And when he attempts to look on the left side, the right eye gets the innervation. So it's an abnormal innervation coming at the wrong time. And this is also known as simultaneous abduction or a synergistic divergence of the right eye. So this is a pre-op picture and this is the post-op of these. And nowadays the ideal treatment for that is nasal transposition of this split lateral rectus. We split the lateral rectus and bring it on the nasal side and transpose it. Sometimes you may have a little more different problem presenting that on adduction you find the right eye is now going down. So earlier we got looking London, talking Tokyo. Here it is looking Tokyo and the other side is Sydney. So if you have this sort of problem, one eye is looking on the Tokyo, the other is looking towards Sydney, that's the synergistic innervational downshoot or a SID syndrome. So these also have to be managed, and accordingly when we find out which muscle is abnormal, you can correct it. So we move faster now, and what we'll see here is sometimes you may have muscle aplasias. This is also a type of a congenital development of the muscles, and there may be an absence of muscles altogether. So when you may be surprised when you plan a surgery that there is no muscle, like these cases which may have associated scaphocephaly, arachnodactyly, like the Goldberg-Sprintzen syndrome. So they may have large exodeviations, and when we look into the eye, we find the missing extraocular muscles. You may have to do transposition if there are other muscles available. Sometimes there may be all the 4 muscles are missing and you are in deep trouble. Now what do you see here? This is a bilateral, eyes are in the exo. It's like what you call a wall-eyed binocular internuclear ophthalmoplegia, a Webino syndrome. So these children have problem with adduction and they have both eyes fixed in abduction. The strabismus fixus divergence or a Webino syndrome. What is unilateral INOs? The internuclear ophthalmoplegias, like in this left eye, you find the adduction is limited in the left eye, but convergence is retained. So in exam, when you get a case of adduction limitation, always look for convergence. And many a times you'll see that asymmetric convergence. So you keep the eye, pen in front of one eye and the other eye starts moving in more. So the convergence is there of the eye which is having a missing adduction. That confirms that there is a different pathway for innervation which is still there. So it's not a problem of the medial rectus, but the pathway higher up, so which is what? The MLF, the medial longitudinal fasciculus, which is missing. And these many a times may be demyelinating condition or ischemic, so they may recover on their own. So you just need to give time. So this is the same case which is recovered, adduction has improved, and convergence of course was normal. Strabismus fixus convergence can sometimes be a problem of high myopia, and that may be causing this problem. Here the 6th nerve is not paralytic. The lateral recti are not having any problem, but they are positioned differently. It's like you are okay in your studies, but you're deviated. Your performance obviously will go down. You have to just get your path corrected and you will be okay. So this is what we do in these cases. In myopic strabismus, we will reposition the superior rectus which has been deviated on the nasal side and the lateral rectus which deviated down. So we bring the superior rectus and the lateral rectus in the superiotemporal quadrant. So if you see the coronal CT is what you'll find, the angle between the SR and the LR is not a right angle one, but a high obtuse angle. So a coronal CT will tell you that there is a weak SR-LR band, and usually the high myopes will have this problem. So look for these. For PGs, you may have a sagging eye, a heavy eye, or a knobby eye. A sagging eye is one in which the eye is just looking down. In heavy eye, the eye is also hypotropic, and it's usually more than 12 diopters myopia. And knobby eye is a very high myope, like 20 diopters, in which the bulging of the sclera is causing a problem of movement. So myopic strabismus fixus, we will correct the thing by SR-LR loop myopexy, and may sometimes require MR recession. Interesting thing is many cases may not require a MR recession. Thyroid is another problem which may confuse you at times, and typically on X-rays what you find here is that there will be a fusiform dilatation of the muscles. Okay, so that is keep in mind on ultrasound or these that you'll get it. So these cases, they may have a limitation of movements, and you may correct them as per the FDT and do that problem. So I think we are running short of time, so we'll just skip this restrictive problem sometimes, or a blowout fractures which may cause. Finally, DVDs, keep in mind that they may have a tendency to have a phoria or upward movement. They may also have associated horizontal deviation or a torsional deviations. So these can be checked by Spielman occluder. You'll find that the left eye is going up, and when you have a filter in front of the other eye, you'll find that the eye self-corrects. It's because of a light-dependent change. These cases can be corrected. If you have an inferior oblique overaction, you do a anteropositioning of the inferior oblique. But if there is no inferior oblique overaction, we may do either a superior rectus recession or an inferior rectus plication. And finally, the skew deviations, which is another aspect of the eye movements which are affected because of a vestibular ocular reflex going wrong. And here you may find that these cases, there may be a pathologic OTR or ocular totalic reflex. So these are rarely which may be seen by you unless you have a good practice. So these can be managed specifically as per requirement. So I think what we have covered is these complex cases: Duane's, Brown's, Mobius, congenital fibrosis extraocular muscles, synergistic divergence, dysthyroid problems, trauma and cysts, myopic, DVDs, and skew deviations. Thank you all for your patient listening.